I'd like to welcome those in the room and also online, quite a crowd today to is it seventh edition, I think, of the Global Health Politics, maybe eighth this year of the Global Health Politics Workshop. This time, we're very pleased to be here at the Department of Global Health at Boston University School of Public Health, here with Pat Hibbert, Department Chair, and here featuring today Dr. Lioba Hirsch, who's going to be talking about her new book, Anti-Blackness and Global Health, the response to Ebola in the Colonial Wake. Please help me welcome Dr. Hirsch.
Great. Hi, everyone online. Thank you for coming. I'll try and do my eye contact with the camera and with people in the room as I go along. I want to start by saying thank you to Joel for inviting me, Party Center for hosting the workshop, to John for handling a lot of the behind the scenes, and I think Patrick as well. And I think there were a few more people who handled all of the logistics in getting me here. So thank you. I also wanted to, I guess, acknowledge the moment a little bit. It feels like, well, I guess we have been in quite a difficult moment for a while now. I wouldn't say that it's recent, but I guess it feels like its intensity has sort of ramped up over the last few months, not just in the US, around the world. And I just wanted to say that I think it's especially in moments like these that it's really important to meet and to keep talking and to listen to one another, to keep learning from one another. And I think to protect spaces such as this, to give voice to different and often marginalized types of knowledge. And yeah, I want to say a big thank you to everyone involved for doing that. Let's try and keep doing all of those things. Let's try and keep connecting and talking to and listening to one another. In preparation of this talk, I went back and looked at some of the older ones, and I watched Kim Yi-dion's talk about medicine and money, I think in Malawi it's called. And at some point she talks about the title of her book and how she hated the title of her book, and how she didn't choose it. And so I can't say the same. I did choose this title. It's the title of my doctoral thesis as well, that this book is based on. But I still feel like I need to, or want to, be accountable for the title to a certain extent. So obviously the book is called Antiblackness and Global Health. Also, obviously, it deals with a global health event in Africa. And I discussed this, I think, in the introduction to the book. I could have called the book Anti-Africanness and Global Health, right? And I didn't. And the reason why I didn't is because anti-Blackness holds a lot of currency, I think, right now, in academia, but also beyond, in like political and social movements. But in doing so, in sort of, I guess, prioritizing the currency over, I wouldn't say accuracy, but I think what I'm doing in choosing this title or prioritizing this title is that I contribute to a form of silencing or erasure, to a certain extent, that still values Black life, and I think especially life of African descent, more if it's removed from Africa than if it is in Africa. I think as someone who grew up in the diaspora, that's a form of privilege that I want to be accountable for. And I just wanted to speak to this with regards to the title, because I think it's the choice I made and I stand by it, but I also think it's good to be accountable for it. Yes. I wanted to start by drawing on the words of Teju Cole. So this book, obviously, like all books, wouldn't exist without drawing on a lot of writing and thinking and I guess teaching by a lot of people in a lot of different disciplines that have come before me. And one of the people that I keep coming back to is Tijukul, because I think that he's politically very poignant, but also he's a terrific writer. And so in 2012, he published a series of tweets on the white savior industrial complex. And then that he developed that into I think a blog post. And one of these tweets, I think, or definitely one of the sentences that comes up in the blog post is, if we're going to interfere in the lives of others, a little due diligence is the minimum requirement. And I think that sentiment is really one that animates what the book is about, or what I try and do in the book. Not just in the book, I hope I try and do this in my work more broadly, on global health institutions, such as the London School of Hygiene and Tropical Medicine, or MSF, Doctors Without Borders, right? And I think I do this not, or I agree with Cole on this, not because I'm out to get anyone. Like, the book is very much about structures of anti-Blackness rather than individuals being racist or being horrible. But because I think, or I agree with what Sylvia Winter said in an interview in 2006, and she quoted Lewis Gordon here. She said, "We live in an anti-Black world, a systematically anti-Black world, and therefore whites are not simply racists. They too live in the same world in which we live. The truth that structures their minds, their consciousness, structures ours." And I profoundly agree with that. I think it's very much about the world that we live in and that global health and humanitarianism intervene in. And it's about holding those structures and the people who operate, all of us, as we operate in them, to account. So this is a book, Antiblackness and Global Health, is very much a book about global health knowledge. It's about what types of knowledge we think are valid in global health and global public health, what types of knowledge are prioritized in how we think about global health as a field, as a discipline, as a practice. And it's really also about the types of knowledge that haven't traditionally been included in global health. And so one thing that I wanted to do with the book was to take embodied knowledge and embodied experiences seriously. I think this doesn't happen enough in global health. I don't think it happens enough in health sciences more broadly. I think if it happens, it often happens sort of at the margins, or to the side, sometimes as an afterthought. And what I wanted to do with this book was to center those forms of knowledge and really offer an analysis of a global event that does this. For those unfamiliar with experiences of racism, and I think I can generalize a little bit, like certainly like my personal experiences of racism often leave me feeling uncertain. They make me doubt what I know and what I experience, and whether, you know, what I experience really, like, did this really happen? And I think the way that sciences generally, but health sciences in particular are set up is that, like, if we doubt something, we often don't include it, right? Like, it's quite positivist. We then say, okay, we're not quite sure, we're leaving this out. And I think what that does is that it replicates an idea of the world that doesn't take racism seriously, and that doesn't take experiences of colonialism and exclusion and coloniality seriously. And so what I wanted to do with the book was to hopefully contribute to a growing canon of works that do that say, actually, this is something that we need to take seriously. And if we haven't done so before, it's not because it's not valid, it's because the way in which we teach and understand and practice science has historically been exclusionary to those kinds of knowledge. And so I do this in drawing on a very wide range of thinkers who, again, traditionally don't really have a space in health sciences and medical science in global health. These are, for the most part, people of African descent, either living in the diaspora. And I think what I contribute with the book a little bit as well are to foreground diasporic ways of knowing and saying, actually, like, they should have a voice and they should have a place. in how we understand global health. And I can speak more about Sierra Leone and diasporic ways of knowing later, if of interest. But I also draw on quite a few Sierra Leonean thinkers and historians who have written about histories of and experiences of biomedicine and health interventions in Sierra Leone historically. And I hope that by bringing them together and bringing them in connection with a global health event today, that it allows us to look at global health events generally, but this one in particular a bit differently, and that it hopefully offers answers and new ways of thinking and understanding global health. So very briefly, I don't want to go into the chapter structure too much, but like, how does the book tell the story of Ebola? The book moves a lot, and I think in a way the structure of the book very much reflects how I did research. I did ethnographic research, and I conducted a lot of interviews with global health responders and medical responders and volunteers who worked in Sierra Leone, both British and Sierra Leonean and British Sierra Leonean, so members of the Sierra Leonean diaspora in the UK. And so that means I conducted historical work. I did a lot of archival research, and also did research in Sierra Leone, did research in the UK, in between those two places. And I think that, I guess, in a way that like multi-sited ethnography allows me to interrogate the ways in which anti-Blackness sort of like creeps up in all of these different aspects of how global health is built, right? Because like the Ebola intervention as itself obviously relied on like huge amounts of expertise, of technology, of resources that were either shipped from the UK, already existed in Sierra Leone, came from other African countries. And so looking at like all of those places in conversation with one another, I think hopefully allowed me to like paint a picture of a response outside of the confines of like treatment centers in one particular country at a particular time. And so in doing that, I look at spaces, at mobilities, at infrastructures, both built infrastructures, clinical spaces, spaces of healthcare, but also epistemic infrastructures, right? How do we think, how have people traditionally thought about health and infectious disease control in Sierra Leone? How do those types of knowledge structure or have structured the response in 2014, 2015? And another concept that is really dear to me and that I keep spending a lot of time on is the idea of care. And so what I do in the book is I look at care as a practice, at healthcare, as a clinical and medical practice. But I also look at the ways in which healthcare and biomedical care, in particular in Sierra Leone, have, from the very beginning of the introduction of biomedicine in Sierra Leone by British colonial powers at the beginning of the 19th century, been entangled with histories of the transatlantic slave trade and colonialism. And so I argue that it's now very difficult to disentangle those, but in a way that's very much what happened during the response, right? Like those weren't seen, biomedical care today and during the response, it wasn't seen as a continuation of histories of biomedical care and intervention in Sierra Leone. And so one of the main questions that the book asks really is, how do we analyze an epidemic and its response from a Black point of view? And I think some of the ways of like moving between the past and the present, taking those different approaches to temporalities and to history seriously, I think I've already evoked, but another one that is really important and that I wanted to spend a couple of minutes on is what Christina Sharp calls wake work, right? So it's sitting with the dead, it's not acknowledging past life, and it's certainly acknowledging the ways in which Black lives in the diaspora and in Africa are often cut short prematurely. And so I wanted to bring up, and I'm not the first person to do this, other people have done so and have put these two deaths in constellation with one another, but I do so again in the book, and I wanted to do so here. So these are two photos. The person at the top is Dr. Sheikh Umar Khan. He was Sierra Leone's leading hemorrhagic fever specialist. He basically built Sierra Leone's Lassa fever program, maybe not from scratch, but yeah, pretty much. And he was leading Sierra Leone's response to Ebola from the beginning of the epidemic, from when it crosses over from Guinea into Sierra Leone in around May 2014 until he passed away in July. Dr. Khan was caring for Ebola patients in a hospital in Kenema, in northeastern Sierra Leone. I always get confused because the country's around, but yes, northeastern Sierra Leone, yes. And he contracted Ebola, and he decided that he didn't want to be cared for by his colleagues because it could be conflict of interest, like ethical issues. And so he checks himself into an MSF Ebola treatment center nearby. And he's relatively stable at the beginning, and the MSF doctors try and decide what to do. They had 2 doses of an experimental Ebola drug, ZMapp, at their disposition, but they decided not to give them to him because they were worried that if the effects were adverse and he would die from the administration of the drug rather than Ebola, that would create, I guess, communication and I guess like public perception problem, and that people would blame MSF basically for killing Dr. Khan, and that they would refuse to come to the MSF treatment center, etc. They also don't consult Dr. Khan about whether he wants to be given the drug or not. They decide not to give it to him. His condition deteriorates, and he passes away on the 29th of July, 2014. That same day, officials from the CDC fly from Liberia to Sierra Leone to get those 2 drugs. They bring them back to Liberia, where 2 missionary doctors have contracted Ebola, and they ask them if they want to be given this drug. They say yes. They give them the drug. They medevac them to the US. They both survive. And so I think this is a really important example of African agency being negated, of decisions being made for, in this case, a leading infectious disease specialist who probably should have had a say in whether he wanted to be given this drug or not. But in any case, it like showcases a constellation in which African life is very actively deprioritized, and 2 white American lives are saved. The second photo is of Dr. Olivette Bach, another Sierra Leonean doctor. She worked in Lamni Government Hospital in Western Freetown, and similarly to Dr. Khan, she cares for Ebola patients. During the pandemic, she contracts Ebola, and in her case, the then president of Sierra Leone, Ernest Bai Koroma, appealed to the WHO for her to be medevaced. And there was a hospital in Germany that had agreed that they would take her. And at the very last minute, the WHO refuses to medevac her, and she passes away. And again, a few days later, 2 Dutch volunteers who think that they may have contracted Ebola flee to Ghana because they're terrified of medical care in Sierra Leone. They flee to Ghana, take refuge in the Dutch embassy in Ghana, and then medevaced from Ghana to the Netherlands, and neither of them contract Ebola. And I think I bring this up for 2 reasons. I think on the one hand, it sort of shows the like consolational thinking that is really, and again, this is a term that I'm borrowing from Tiju Cole, that is really crucial in the book, that I think is really crucial when it comes to like understanding how anti-Blackness works today, not just in global health, but generally. I think very often when we think about anti-Blackness or racism, we think about like the KKK, or we think about like racial slurs. Very often racism can be very polite. Like I think institutional racism can be very quiet and innocuous, if you can say that. And I think it's really important to understand that if we are to like work against it. I also bring it up so that we can remember these 2 people who worked for the people of Sierra Leone, who had the expertise and the training to do this. Because again, I think very often in humanitarian situations, we tend to think that there's no expertise on the ground, and that's simply not true, right? Like Sierra Leonean doctors have been like fighting against infectious and other diseases in varying circumstances for centuries, and they continue to do so. And so the way in which anti-Blackness, as I just said, sort of occurs and like rears its head and like structures global health and I would say probably the world, is in a way that, as I said, is often silent and like imperceptible, especially for people who don't have lived experience with racism and anti-Blackness, right? And here I'm borrowing Adia Benton's term epigrammatic, and she argues that anti-Blackness or like racism is often epigrammatic, and what she means by this is that it sort of hovers like to the side and like above the room or us, right? Like it's there, but it's like a bit difficult to perceive, and if you turn your head, you might not see it, or you might just glimpse it, and then it flits away. And that is very much how I write about anti-Blackness in the book, right? It's something that is there, and it's very obvious, but also something that is constantly, actively being negated, not because people, not willfully, because people don't want to acknowledge it, but I think because very often our brains don't want to confront things that are inherently uncomfortable. And so I put this quote in. I want to share this quote with you, which is in the book. And again, it's not because I think this person who was a nurse, obviously everyone's been anonymized and has been given pseudonyms, but so this is a British nurse who works in an Ebola treatment center in Sierra Leone. And we were doing an interview and talking about some of the training that British volunteers received before going out to Sierra Leone. And part of the training was cultural training that was being offered by members of the Sierra Leone diaspora in the UK, right? And they would give them, I think, like a day or two of like cultural training of like what to expect. And so he said, so we were told that a couple of times. I don't know. White people, British people, and I think it's probably a lot to do with the Civil War, or it might not be. But I met people there who wanted Britain to take Sierra Leone back as a British colony. And I think I must have been surprised because he said, oh yeah, I don't know, I might have a picture. Some of the buildings along the way to Carytown Ebola Treatment Center had Union Jacks painted on them, stuff like that. Yeah, I'm not joking. And people said to me as well, we need the British back. We need you to come back. And the thing was, it was a long-term British colony a long, long time ago. And freed slaves were settled there. And there was a lot of back in the 1800s of philanthropy, and people set freed slaves up in their own town and all that. But we were actually told on the first week that that they look up to British people or white people. And I found that really strange, but I don't know. I don't know if I saw that really. Working with Sierra Leoneans, I saw that. I think there was a lot of acknowledgement of our skills. They wanted to learn, but that's not looking up to someone, is it? And I think that's a really good example of like how we are all able, like within one statement, to like acknowledge something and then distance ourselves immediately, like verbally, from it, and come to a very different conclusion from what this person was told, right, by the people who did his training. And again, this is how like anti-Blackness operates very often, right? It's like it's there, but we work very actively to not have to acknowledge it. And that photo is a photo that I took on the way from Freetown to Carytown, where indeed there are like several, and same in Freetown, several buildings and structures that have the Union Jack painted onto them. And so what I want to do in the book, or what I hope I do in the book, is that I relate anti-Blackness and think about anti-Blackness in relation to infrastructures, right? Medical infrastructures, health infrastructures. But what I also do is that I think about anti-Blackness as an infrastructure, right? Something that is there, that is almost like a conduit through which knowledge and expertise and logistics and structures and materials flow in a way. And so I think about anti-Blackness as an infrastructure that is mostly epistemic, but that definitely leaves traces in material forms and also in absences. And again, right, those absences and those silencings are really, really important in the book. And I just want to share a definition of infrastructures by Susan Lee Starr, who wrote that infrastructures are by definition invisible, part of the background for other kinds of work. It's ready to hand. One person's infrastructure is another's topic or difficulty. And I think that's quite a good definition. It's sort of like, right, it speaks to the way in which infrastructures are always there, but really we don't notice them unless they break down. And I think that's, yeah, again, like definitely a way in which anti-Blackness operates in global health that is, yeah, by definition invisible and part of the background for other kinds of work. One of the main questions that I try and answer in the book is what landscapes global health politics intervene in. And to me, landscapes in general, I trained in, well, my PhD was in global health and geography. And so environments and like landscapes are really interesting to me and are very important to me. And Sierra Leone, but really any place, presents a bit like a palimpsest, right? Like layers and layers and layers, like writing and history and sociology and economy and like all like stacked on top of one another. And it's not always easy to like see all of the layers, but sometimes you sort of get a glimpse and sometimes you don't. And environments, very much like knowledge, I would argue, are always felt and experienced. My experience of like walking through Boston is very different from like all of your experiences. It's not from here and my personal history, et cetera, et cetera. And I think that was definitely the case with international responders who came to Sierra Leone and who had very different relations to Sierra Leone than Sierra Leoneans who have grown up there and lived there all their life. And the same can be said about members of the Sierra Leonean diaspora who had different ties to the country. And in the case of Sierra Leone, Ebola responders intervened in a landscape that I think celebrates and or had a very perfunctory relationship to the transatlantic slave trade and colonialism. If you walk around Freetown, in the Freetown Peninsula, so Freetown becomes a British colony at the end of the 18th century. And then gradually Sierra Leone, the colony of Sierra Leone, like gets incorporated, like first it's the provinces, and then it gets incorporated more and more over the course of the 19th century. But if you walk around Freetown, there's a lot of memorialization in street names and place names of British abolitionists, right? Like the British abolished the transatlantic slave trade in 1807. They are the first European power to do so, and they forced a lot of the other European powers to go along with that. But there were, and this is what most people don't know, specific caveats. The slave trade was abolished between specific longitudes and was dated. So like Brazilian ships, for instance, were only forced to return enslaved people to Africa if they were caught in a specific region or after a specific date. So in Freetown, we have, and I mean, the name Freetown itself, right, speaks to this, like of histories of abolition and liberation. And that's really interesting. It also negates the fact that before the abolition of the transatlantic slave trade, the British were the main people exporting slaves from Sierra Leone and from West Africa. And I think that's in itself, right, is already a really interesting way in which history sort of like comes up selectively and shapes the landscape. And that, again, like Cormac's quote, is something that I think some respondents were definitely aware of and others were not, but it's not something that was taken into account in the design of, in the political, I guess, design or communication of the response. With Sierra Leone, international and volunteers also intervene in a landscape in which there have been long histories of racist exclusions from medical practice. Sierra Leone, alongside Ghana, from 1904 form one cohesive West African medical service. We had like the Sierra Leonean medical service and the Ghanaian medical service. They are amalgamated into one West African medical service. And drawing here on the work of Festus Cole, and also who's a Sierra Leonean historian, and also some of the work that I did, some of the research that I conducted when I worked at the London School of Hygiene and Tropical Medicine. The West African Medical Service is essentially created to create jobs for graduates of two schools that are newly founded in 1899, the London and the Liverpool School of Tropical Medicine. The West African Medical Service is also the first British government service that is openly racially segregated. So from the creation of the West African Medical Service, or it's written into the creation of the West African Medical Service, that only doctors of European descent are allowed to become medical officers. Until then, it was a completely integrated service, and West Africans were allowed to rise to all ranks, and actually in the case of Ghana, rose to very prominent ranks towards the end of the 19th century. This stops with the creation of the West African Medical Service, and it doesn't mean that Sierra Leoneans aren't allowed to become doctors, but they can only rise to the rank of, I think, native medical officer, which is the junior rank. And so, with the Ebola epidemic, where roughly 60 years post-independence, right? And obviously the West African Medical Service was dissolved before. But again, I think it's really important to bear in mind, right? That this health intervention intervenes in a landscape in which practices of biomedicine have this history of racial segregation. Finally, it's also a landscape which from a British or European, or I guess a Western point of view, has from the beginning of Sierra Leone's often forceful integration into the world economy and the transatlantic world been phrased as dependent, right? Sierra Leone has never been seen, or West Africa, or Africa generally, have never been seen as equal to Europe or North America. And so those definitions and those imaginations of Sierra Leone as a country that is dependent on Europe and on European help and intervention, which starts with the creation of Sierra Leone as a British colony, which is a philanthropic project at the time, similar to Liberia, right? We will buy this land, and we will offer a land to freed slaves so that they can govern themselves, is one that structures British relationships with Sierra Leone from the get-go, really. Another big question that I try and answer in the book, or that I maybe an argument that I advocate in the book, is that we need to rethink global health temporalities, right? So a lot of the book, as I said, moves between the past and the present, and looks at continuities really, and also ruptures in how Sierra Leone has been conceptualized from Britain, in how infectious disease control and medical expertise have been thought of and have been conceptualized in between the UK and Sierra Leone from the get-go. And one of the things that I argue for is that I think we need to rethink these global health temporalities, and rather than seeing time as linear, we need to start looking at these as occurring one next to each other, or being in close contact and conversation with one another. And I ask, what happens when we start seeing these temporalities side by side, right? What questions does it open up? How does it change our perspective? Where does it draw our attention? And I think doing that becomes really important when we start thinking about questions of trust and refusal of biomedical care, right? Which became a huge topic, not just in this Ebola outbreak and subsequent Ebola outbreaks in the DRC, and then subsequent infectious disease outbreaks, or medical interventions generally, where people often refuse to surrender themselves to biomedical care, whether it is being practiced by Europeans or North Americans or locals alike. And so I argue in the book that rethinking these global health temporalities really forces us to rethink care as well. And so this comes out in the book in various ways, or I speak to this in various ways. And so one example is the way in which people either refused to or were very suspicious about going or like bringing relatives to Ebola treatment centers, and how those treatment centers were seen. And so this is a map that one of my interviewees drew for me during an interview. It's of an Ebola treatment center in Sierra Leone. And we were talking about, I was interested in infection prevention and control and how it works out spatially. And I asked her to draw me a map. And she drew me a map and she sort of said, okay, well, so like in the top left-hand corner, that's the red zone, right? So like those unfamiliar, infection prevention and control create zones and flows to prevent contamination. And they're often labeled by color, green, orange, red. And so Ebola treatment centers were generally separated into green zone. So that's like where like kitchen and offices are. Orange zone is where suspect cases are, and then red zone where confirmed cases are. And so she drew me that map, and then as we're talking, she said, oh, and like in the bottom right corner, labeled military, that's the white worker treatment center. And I said, excuse me, what? Like, what is like, and she said, well, like this treatment center had a specific sort of sub-treatment, like a treatment center within a treatment center that was specifically for international volunteers. And so herself and the like Cuban staff who worked there started calling it the white worker treatment center. So to say like, why is there a separate zone that is only accessible for international volunteers and that is not accessible for like the Sierra Leoneans don't have access to? Now, like on paper, this was always meant to be accessible to, so this was always meant to be accessible to healthcare workers in general, not just international healthcare workers, but somewhere at some point, something happens and either this is definitely the case or there's definitely this like perception like grows around the space that it's only accessible to white volunteers. And apart from that, like that in itself is a very interesting fact or anecdote. But apart from that, what in the book, what happens in Ebola treatment centers due to the completely unwittingly, due to this separation into green, orange, and red zones, is that it categorizes people according to their likelihood to live to a certain extent, right? If you're in the red zone, you're in pretty big trouble, whereas if you're in the green zone, you're okay. And this, in a way, aligns with quite a lot of writing from Black studies, and I'm drawing here on the work of Alexander Wehelier, who writes that race, rather than being a biological or cultural category, is a set of sociopolitical processes that discipline humanity into full humans, not quite humans and non-humans. And in a way, that is what happens, right? Not by design, not because anyone, I assume, like set out to say, like, this is what we're going to do. But what we have de facto are treatment centers in which 100% of the patients are Black Sierra Leoneans, and a majority of the volunteers are European volunteers, white European volunteers. It also comes out in relation to pre-existing treatment facilities, right? So the previous example was a temporary facility that was built from scratch at the beginning or throughout the first month of the outbreak in order to cope just with the quantity of patient cases. A lot of the pre-existing hospitals and clinics, and I can go into this more during the Q&A if you're interested, again, for like colonial reasons, weren't suitable for proper infection prevention and control protocols. And so a lot of these temporary structures were built. But in the case of, this is Colonial Hospital, which is the main adult referral hospital in Sierra Leone, so like which used to be the Colonial Hospital, it's a relatively big structure, and that was actually used, they created an Ebola ward in Colonial Hospital, or were able to do that. But in part because of the history of Colonial Hospital and also because of its long association, like Colonial Hospital is probably like the biomedical institution in Sierra Leone, just because it's the biggest hospital. People were refusing to go to Colonial Hospital to be treated. And again, these are just a few quotes of people who worked at Colonial Hospital that show people's reluctance and the rumors and the levels of mistrust that led to people not wanting to go and seek biomedical care. And so one of them said, a lot of our early problems were not so much that Ebola was a curse, not a virus, it was that Ebola was a conspiracy. So there was a belief that we were taking patients into the unit to kill them, inject them to kill them. Another doctor said, one of our patients talked about how his belief before he got sick was that they wanted our blood. People who didn't have blood had come to take his blood. And when he got sick, a nurse he had known from his community for many years treated him in the Ebola unit, and rather than believing her, he simply believed that she had been kind of co-opted and they'd come to take his blood. And that must have been September, October 2014 time. So like a while into the outbreak, right? And then finally, this is from an administrator who worked at the same hospital and who said, I heard rumors about people getting killed in those places, in hospitals and Ebola treatment centers, or that it was all a big conspiracy. But considering the availability of information in this sort of context, I'm not going to say they're unreasonable. Sorry. And so in the book, I linked this to Louise White's work on rumors and vampire stories in Central and East Africa. And what she does and what I do in the book is like link this back to like colonial medical interventions and the ways in which they intervene in communities, often without consent, and basically from the get-go tied biomedical practice to these really extractive and often violent practices of care. And so, as I said, care and like histories of care and healthcare's entanglement with these violent and colonial and anti-Black structures and histories is definitely a central theme in the book. I put Christina Sharp's quote here. This is from her 2023 book. I think it's 2023, Ordinary Notes. And in it, she writes, care is complicated, gendered, misused. It is often mobilized to enact violence, not assuage it, yet I cannot surrender it. I want acts and accounts of care as shared and distributed risk, as mass refusals of the unbearable life, as total rejections of the dead future. And I think this quote is really powerful. And I think, again, it like resonates with like what I try and do in the book to a certain extent, right? Like care is something that's really important to me, like as a method, but also healthcare is really important to me. I think it's incredibly powerful and we need it. And at the same time, I think we do need accounts of like its violent past and histories and the way in which it has, like in the case of Sierra Leone, from the very beginning, in terms of in the case of biomedical care, been entangled with these violent histories. And we need to be aware of that if we want biomedical care in the present and the future to not be encountered by the same levels of mistrust and rejection. It's really difficult, I think, to sort of like summarize the book in 40 minutes, but I thought I would nearly end with this. I have one more slide afterwards. If there is a summary of the book, I think maybe this is from the conclusion, where I write that I want us to understand the wake as a political and geographical reality that affects all of us. I want us to notice again and again how anti-Blackness and colonialism are at once normalized and marginalized in global health and in the Ebola response. I propose that we take colonial infrastructure seriously and that we pay attention to their endurance and the ways in which they shape global health. A challenge. Let us politicize and interrogate practices of care. Let us approach them with caution. Finally, an invitation to use care as methodology in global health research and beyond, to live caring and careful lives, to learn, teach, and share with care. And I wanted to, again, end with words that are not my own. And again, this is by Bonnie Honig, who's quoted in Christina Sharp's earlier work. And she wrote that to care is to cultivate anticipation of another world and to live now dedicated to the task of turning this world into a better one. I think it's a really powerful quote. I hope that maybe the book contributes to this in like a teeny tiny minimal way. But I think, like, more importantly, I think it's a really important call for like all of us to try and practice this and do this in the work that we do in global health and in health sciences and in our lives and politics more generally. And I'll end there. Thank you.